Hello, everyone. I hope you can see my slides okay. It's
Yes,
really a great
yes.
pleasure to be here with everyone and participating in this session with AIOS and the Cornea Society. So I'm going to be speaking about role of phakic IOLs in correcting astigmatism. I have no financial conflicts of interest. I'll start talking about a case. This is a 35-year-old male who presented in our refractive surgery clinic to see what we could do to help him reduce dependency on glasses and contact lenses. He just has a history of wearing glasses and in the past has worn rigid gas perimeter lenses off and on, but was out of them for at least 2 months prior to presentation for his evaluation. No other really pertinent history except in his social history. He is an engineer, pays attention to details, interested in seeing well, and you can see his hobbies listed here as well. His refractive error was stable at a refraction, as you can see here. He's a high myope, minus 950, minus 1050, with a high degree of astigmatism in both his eyes, but is able to refract well, corrects to about 20/20 with that working distance with those glasses and with the manifest refraction. His cycloplegic refraction was similar as well. His other exam findings, he has relatively thin corneas, but otherwise relatively stable, maybe a little bit on the drier side. Here is his corneal imaging in his right eye. You can see that his central Ks, although are relatively within normal range, he clearly has a pattern of inferior steepening with a Kmax over 50. A bit of posterior elevation, although somewhat decentered superiorly, and again, confirming the relatively thin cornea. And the left eye has similar findings, if anything, slightly worse than the right eye was. So certainly when patients like this present, there are options to consider. We can certainly talk to patients about continuing to use their glasses and contact lenses, especially if they're functioning well with them. But if they're looking for glasses or contact lens independence, what can we consider here? Corneal laser ablation is not a good option in this case because of all the obvious factors: high correction, astigmatism, thin cornea, and irregular corneal topographic pattern, really consistent with keratoconus, although he refracts to 20/20. So therefore, lens-based surgical options are important to consider, including phakic intraocular lenses and refractive lens exchange. In this particular case, he is also 32, so being at the age he's at, preserving accommodation is a factor. So we chose to do a phakic intraocular lens approach with the EVO ICL. This basic surgical technique is relatively simple. 2 paracenteses, 1 to 1.2 millimeters. You want a good dilation, although we attempted to dilate him preoperatively. He did not have great dilation, but with intracameral lidocaine and epinephrine dilated fairly well. Using a viscoelastic, but not overfilling the anterior chamber is really critical because the viscoelastic will get trapped underneath the ICL. The incision is a little bit larger than our typical cataract surgery incision, closer to 3.0 to 3.3 millimeters to allow the lens to be injected. There are a couple of injectors that the Star ICL comes with. You want to try to avoid as much air bubbles as you see here because they will obstruct your view, but the lens goes in fairly quickly, so you have to kind of control the modulation. You can put viscoelastic on top, and then it's tucked into the sulcus underneath the iris and positioned with the alignment marks to allow for the astigmatism correction. And for the most part, the amount of manipulation you have to do is relatively limited, up to maybe about 20 degrees to off-center from the 180-degree axis to allow for proper astigmatism correction. And then usually it takes a little bit of Myocal to constrict the pupil on top and flush out the viscoelastic with bimanual IA. This patient did very well, even on the day of surgery, which is an important part of follow-up care for these patients to make sure the IOP is okay. Was 20/20 uncorrected, and even by 1 week had a very good uncorrected vision, was very happy with his outcome. In the United States, we've had A few options available for phakic IOLs. The anterior chamber lens format is not available anymore, although it was for a number of years. The Visian platform for STAR was the main type of phakic IOL that was utilized until recently with the availability of the EVO platform. Both of these, the Visian and EVO, are posterior chamber phakic intraocular lenses to correct nearsightedness only. And really, especially for the Visian, maybe less so for the EVO, the higher corrections are really for reduction of myopia. Correcting up to -20 is challenging, predictably, but we can correct astigmatism up to 4 diopters. I'm going to primarily talk about the Visian or the STAR platform ICLs and EVO, because this is what is the main phakic intraocular lens that we utilize in the US at least. This is a collagen copolymer material that has been utilized for really nearly 3 decades in different lens platforms. It's highly biocompatible, hydrophilic, and has strong tensile strength and resists tearing as you're putting it in. Does have a UV absorbing chromophore. It functions by placing the sulcus with a vault over the natural lens. The haptics, again, are placed in the sulcus with a 500 micron optic over the crystalline lens centrally. There are 5 full thickness ports, which are 360 microns in diameter, which was felt to be an optimal size to allow aqueous permeation around the lens to minimize injury to the crystalline lens over time and minimize cataract formation. The selection criteria as defined by the FDA approval process are for high myopia between ages 21 and 45, and again, cylinder up to 4 diopters. The spherical equivalent range is -3 to -20. Of course, you want to make sure the patients have a stable refraction, and one critical measurement for phakic IOLs, of course, is the anterior chamber depth to be equal or greater than 3 millimeters. It is important to consider endothelial cell density, and the requirement for endothelial cell density, or the recommendation at the very least, are based on patient age and anterior chamber depth. Younger patients should have higher endothelial cell count ratios, and of course, the deeper the anterior chamber, the requirements are a little bit lower, but this table can be utilized as a guide in making decisions about selection criteria. If based on FDA criteria, again, this is not approved for patients who are less than age 21. The typical other things that we consider are pregnancy or lactation. Based on the placement of the lens, of course, corneal pathology and endothelial cell counts become very important, as well as the anterior chamber angle and degree of glaucoma, if present, may be a big factor as well, all related to the anterior chamber depth. Preoperative evaluation certainly includes a full ophthalmic examination, which again should cover endothelial cell density, gonioscopic assessment of the angle, the axial length, and a horizontal white to white, which is typically what's used for sizing the lens for placement in the sulcus. And then STAR has its online platform for calculation for what lens to order based for the size and power of the lens. Because it's a hydrophilic lens, it's really essential to keep it moist throughout the process and really try to inject it once it's taken out of the balanced salt solution it's stored in, and placing the injector into the eye within a few minutes. So timing is important to minimize any injury to the lens because it's hydrophilic. Couple of different injectors available, the Lioli's, the newer version that STAR has, which both are relatively simple to use and allow predictable injection of the lens into the eye. With respect to the OVD, it's important to use, the recommendation is for a low molecular weight hydroxypropyl methylcellulose or a dispersive agent with low viscosity so that it's easier to remove but coats the surface where you need it to. The vaulting of the lens is really a critical feature in terms of minimizing issues with respect to injury to the lens, as well as reducing risk of having IOP or cell count issues over time. The optimal vault is 250 to 900 microns, but essentially about 50 to 150% of the corneal thickness. I usually try to size it to the thickness of the cornea as long as it's in the normal range. Vaults that are too high may, or too low or too high may cause problems. In the bottom set of pictures, the one on the very left of your screen is a normal vault. Here, there's a minimal vault and it's too flat. And on the right, the vault is too big. And that, of course, that correlates to the anterior chamber depth as well. So what about the data in the US FDA studies for the EVO approval? This was a series of 200 eyes with a mean refractive error preoperatively of minus 4.6. They showed at the 6-month follow-up that 94% of patients were 20/20 or better. With respect to how many patients distance vision gained vision lines, really essentially all of them were no change or had gained additional lines of vision. A retrospective review of studies published on the EVO platform with over 4,000 eyes found similar results, that over 90% are within half a diopter of accuracy of correction, 99% nearly within 1 diopter of target, and complications with this platform relatively low in this series of patients, with no cataract formation reported, perhaps related to these full thickness holes. 1 patient with pupillary block still reported, and minimal other issues overall. How about the Toric ICL platform? This was a series of patients looking at a refractive error of -9 sphere and -2.67 cylinder, showing follow-up to 12 months with very stable results and good correction of spherical error and overall good correction of cylinder as well, but not as good, not fully corrected. Patients do end up on average having about a -0.5 refractive error. What about complications? There is a whole host of complications to consider. Preoperatively, they're all really based on sizing and power of the lens to get the best results. In the Visian platform, we did need to make sure that we had adequate sized peripheral iridotomies, but that's not so much of an issue with the EVO platform. Intraoperatively, most of it is really related to the insertion and filling of placement of the lens in the sulcus to avoid trauma to the crystalline lens, and also to make sure that we avoid trauma to the corneal endothelium and minimize issues with intraocular pressure. Long-term complications, it's important to recognize that these patients can have significant glare and halos, and even with the, these are results that are focused more with the Visian and Verisize. We don't have great results still available with EVO platform, but in general, the rates are significant enough to it's important to share with patients, but tend not to be severe enough to be too functionally disabling, although patients do report night vision and night driving difficulties, especially with the Verisize and Visian platforms. Broader issue with cataract formation also seems to be lower again in published series with the EVO platform, as well as IOP elevation not reported again. Endothelial cell count loss can still occur with, of course, with any of these platforms based on surgical technique and sizing of the lens, but seems to be on the lower end with follow-up. So just in summary, it's important to consider use of phakic intraocular lenses because they can allow us to correct a much wider range of refractive error and can be utilized in relatively thin corneas, even if they have other issues such as dry eye disease. They're overall relatively safe and have long experience in use, especially with the ICL and posterior chamber placement. And theoretically, they are removable, although that's not something we necessarily advise our patients when making these decisions. Thank you.
Thank you, Dr. Mian. And while I'm